So with over 240,000 deaths thus far, the outbreak in the US is continuing to grow steeply and spreading widely. COVID-19 is exposing the systematic frailties in our pandemic preparedness, in our social security safety net, and above all, in our healthcare coverage. These frailties have exacerbated a series of missteps that combine to fuel the spread of COVID-19 throughout the US. In the hopes that we might learn from our mistakes, I'd like to dissect the factors that contributed to this crisis and to discuss some action points that could help to cauterize the devastation as far as is now possible. So the first misstep dates back to 2018 when the Trump administration dismantled the Global Health Security Unit dedicated to pandemic preparedness that the Obama administration had set up. Without that expertise in place, we fumbled over pivotal opportunities to control the outbreak early on. So, as a consequence, we squandered the first 9 weeks following the reports of a novel, virulent, and transmissible respiratory virus originating in Wuhan, China. By January 21st, diagnostic protocols had been developed by multiple teams, and coincidentally, this was also the date of the first confirmed case in the US. By February 5th, the CDC had ramped up production of test kits and sent them to local public health agencies. Unfortunately, these test kits turned out to be faulty. This is particularly tragic because there were teams outside the US who were capable of producing tests, but federal approval that would have permitted the use of these tests for diagnostic purposes was held back. At that time, suspected cases of COVID-19 were showing up at hospitals. However, the vast majority were unable to be tested. With scarce diagnostic capacity, we were hampered in the early containment efforts, which rely on contact tracing and case isolation. As a result, we were walking blind into the eye of the storm. On February 26th, community transmission was occurring, we now know, in the states of Washington and Oregon. Meanwhile, the US president was repeatedly minimizing the gravity of the crisis and overpromising resources needed to combat the outbreak. As just one example, on February 28th, he said, "It's going to disappear one day. It's like a miracle. It will disappear." Finally, on February 29th, the FDA approved clinical tests by facilities beyond the CDC. And on March 13th, large-scale companies started producing COVID-19 test kits. So these missteps are reflected in the number of tests that were administered in the US compared to South Korea, which had its first case the very same day that we did. The per capita comparison of testing is even more stark. So South Korea is an example of a country that hit the ground running in their implementation of widespread diagnosis that was freely available to everyone, and they rapidly curbed COVID-19. So more than 37 million people in America have no health insurance whatsoever, and another more than 40 million people have inadequate insurance, which means that their copays and deductibles are not affordable compared to their income. And so they go without care that they need. Indefensibly, there are cases of people suffering from COVID-19 who have been denied treatment because they do not have insurance. Compounding the problem, the US is the only high-income country in the world that does not guarantee paid sick leave. In addition to being inhumane, it puts our entire society at risk when some among us do not have the means to stay at home when they or their children are sick. So in our modeling work, and this was in collaboration with Jeff Sachs, we have projected, and this was back in April, we projected the need to expand ICU and ventilator capacity. Unfortunately, these projections were borne out by what has occurred and is now occurring across the US. The influx of critically ill patients is quickly overwhelming healthcare facilities. And some hospitals are even now still grappling with shortages of personal equipment, including masks and gloves. So these shortages cost lives, and I fear that many thousands of Americans many more thousands of Americans will die before the outbreak is extinguished. And the catastrophic scenes that we've seen coming out of, in the early days, New York City, have currently been replicated in every state across the country. Again, this is from our work with Jeff Sachs. So our modeling results also showed the impact that self-isolation can have in terms of reducing and delaying the outbreak peak, both of which are fundamental to minimizing mortality from COVID-19 and buying more time for the equipment, as well as the development and scale up of vaccine candidates, as well as antiviral therapies. So some recent work has focused on silent transmission. An unusual aspect of COVID-19 is that the peak of infectiousness occurs during the pre-symptomatic phase. So for most diseases, people often aren't symptomatic at all, infectious at all until they've become symptomatic. And usually infectiousness increases as someone progresses through the course of infection and their symptoms become more severe. But for COVID-19, it's the highest viral load occurs before the onset of any symptoms, and stays high early into transmission, early into the symptomatic period, and then falls off. So when people are actually dying from COVID-19, they may actually be testing negative. It's at that stage, it's an aberrant immune cytokine cascade that is causing the damage to the lungs and heart, rather than necessarily direct damage from the virus. So in this modeling work, by translating data on viral shedding that I just described, symptom onset and age-specific mixing patterns, we determined that the contribution from silent transmission to COVID-19 spread in and between different age cohorts. The majority of transmission is attributable to people who are not exhibiting symptoms, which means that measures based on early symptoms such as temperature checks are inadequate. Whereas with a disease like Ebola, people don't become infectious and really until they're symptomatic. And so early symptom, which would also be fever for Ebola, is quite an effective measure to prevent community transmission. This is under the assumption that everyone, even if we have perfect and immediate isolation of symptomatic cases, evidence-based decision-making is imperative. Lifting measures will cause and have caused a rebound and will ultimately lead to greater human morbidity and mortality, as well as more pervasive economic repercussions compared with a concerted effort across the country to maintain social distancing until COVID-19 is brought well under control. I mean, we've never, in certain regions, we've controlled arguably COVID-19, but the US as a whole, we have not succeeded in bringing it under control. And as long as we have a disjointed implementation, you know, some parts of the country are just going to keep receding the infection back to other parts that have gone through and put in stringent measures. So scientific leadership, as has been exemplified by, I think, Tony Fauci, is indispensable. And luckily, he will continue in his position with the election going the way it did, thankfully. So accurate communication with the public will bolster the trust that is essential to promote public adherence to policy recommendations. Several state and local leaders have provided upfront communication to fill the gaps where the federal government is failing. But some of you may have seen coverage on CNN that even people who are dying from COVID are still in denial. There was a nurse describing in South Dakota that she has patients who, even as they are dying of COVID, some of their last words will be that, you know, they don't believe it's a hoax. It must be something other than COVID. And so that denial is, I mean, if they're not overcoming their denial in those circumstances, it just shows how powerful the false information can be. Particularly early on in the outbreak, you know, we saw New York State, Massachusetts, several states were literally competing against each other to purchase desperately needed equipment, and that was driving up prices and delaying distribution. So we really need federal coordination of the production and distribution of medical equipment, therapeutics, and vaccines. So this week, we've had extremely promising preliminary results about the efficacy of 2 vaccine candidates, which could be game changers. I just hope the vaccines become widely and equitably available free of charge. A single payer system, such as that proposed in the Medicare for All Act, in which we could fully insure everyone for less than the country is currently spending per capita on healthcare.
Well, thank you, Alison. Thanks for hanging in there. I have to say that everything you have in those slides, we know, we're actually, those of us who've been following this, we know about like these different pieces, but when you collect them all together into one compact set for this presentation, it is very sobering and disturbing because this has been one really, this is a self-imposed disaster of extraordinary scale. Story about someone who's dying of COVID. And so this idea of not that seeing is believing, but that believing is seeing. It's extraordinary. I mean, I don't know how you combat that. I'm glad that, Alison, I was just talking about that astonishing anecdote about someone who's dying of COVID and yet still believes what she, I think you said it was a woman, what she was told to believe, that COVID's a hoax. So that it's not seeing is believing is seeing. And that, you know, how you combat that, I don't know. We will later in the webinar, we have a session, and I hope Elke Weber at Princeton, our former colleague, is a psychologist, and maybe she could help us understand this a bit. But the total dysfunction, top to bottom, is astonishing. I mean, to the extent that I am still in disbelief that our failures could be so profound and persistent. It's astonishing. And so much of this was easily preventable. Now, even something like the healthcare system, that you've made a very, very powerful case that the system we have is both much too expensive and terrible at providing healthcare for many millions of people. And so we could get an improvement that would be better all around. And I think there's no question about that. There is a political question about how you get from where we are. It's an installed system, and with entrenched interests, and with people not wanting to, being fearful of if you have insurance, being fearful of what it's going to be like on the other side. So we have to deal with that transition. I wanted to ask you a question that's connected with that, though, because another point you made was that a lot of this transmission is occurring with people who don't know they're sick, and other people don't know they're sick. And unless there's random testing, you're never going to know they're sick. But if you're going to have a system that's going to pick out people like that, you actually have to have an infrastructure. It can't be something where you just have people who are sick seeking help.
Exactly.
It has to be the case that people who aren't seeking help are tested anyway. And that there's got to be, I'll call it an incentive for those people to participate in that collective effort. So that incentive could just be, I have a conscience, I have a sense of responsibility. We could add, incentives of another kind. Like if you want to continue to receive medical whatever, then you need to show up when we ask you for a test, and so on. So I think that case you make about the healthcare system, basically providing, it's just like it's not a foundation for health, let alone a functioning economy. But on top of that, we need a system like that if we're going to deal with infectious diseases that have the features of COVID-19, transmitting with people who don't show symptoms.
Yeah, absolutely. And we really need to suppress, for COVID-19 specifically, we need to suppress the incidence to a point where we have enough capacity to do contact tracing from each case to identify people who are not yet showing symptoms. And that, that is a challenge. We are, there are, rough estimates that for every daily case, you need 10 to 15 people contact tracing. So we're nowhere near implementing that type of infrastructure.
Right, and to have that kind of infrastructure, you have to have a public that wants government to play a bigger role in society. And since I think you've frozen again, Alison, but since Ronald Reagan stigmatized government, that's become part of the rhetoric in this country, that government isn't effective. And when you do everything you can to make government ineffective, it turns out it is ineffective. But if you don't invest in it and try to make it work, it's not going to work. And so we've had a long history of trying to make government ineffective, and we've succeeded at that, at least.
I think it's really important now to understand two levels of dynamics at play here, a technical level and a political level, in terms of the lack of control of the pandemic or the control of the pandemic. So the logic of controlling the pandemic is, as Alison talked about, getting people who are infectious out of circulation as early as possible. And there are two basic logics of control. One is to stop contacts from actually transmitting the disease, and that is face masks or physical distancing. And the other is that when people are infectious, they're not circulating and they're not transmitting the disease. And Alison's early work that I joined in one paper was showing that if people would self-isolate as early as possible in their infection, you drive the effective reproduction rate below 1, and you can suppress the epidemic. And even if you don't have it so strongly in the examples she showed where you drive R below 1, even if you drive R down, the ultimate attack rate is reduced, because the closer the effective reproduction rate is to 1, but still above 1, you have an epidemic, but it stops at a lower level of attack rate. In other words, only 20% of the population ends up being infected rather than 40 or 60%. All of that depends on people isolating. And what we've learned is several things. First, unlike the basic models, isolating is itself a relative concept, because if you are isolating but in a household where you're actually next to your family or roommates and giving them the disease, that's not real isolating, even if you're not out in public. So the East Asian countries that have controlled the pandemic have placed much more weight on stopping the transmission within the household. So for them, it's been quarantine as much as isolating. Quarantine meaning out of the home in a physical facility, usually public facility like a hotel requisition for the purpose or a gymnasium or something else. So that's one part. And then the second part that Alison was emphasizing is that to isolate early is problematic, because people are infectious before they're symptomatic, even when they do end up being symptomatic, or they end up with such mild cases that perhaps they're never symptomatic, or so mild that they don't really realize that they should not circulate. And so the asymptomatic, the pre-symptomatic, and the mild symptomatic cases are all problems in this regard, because you won't get a lot of self-isolating. And that's where the active surveillance that we've talked about in earlier weeks comes in, that people have to be notified, you have been in harm's way, you are likely to be infected. I feel fine. You are likely to be infected. You have to get tested, and you have to stay isolated during this time until it's verified that you are not infectious. So active surveillance tries to reduce the period of infectious people circulating even more by letting people know and finding actively people who are likely to be infectious but not even know it, because they're asymptomatic or pre-symptomatic. And that's all the technical side. I think what is amazing is that if you take this combination of active surveillance, effective isolation, and face masks and physical distancing, it all adds up to an effective reproduction rate less than 1, which means you actually suppress the epidemic. And there's no a priori reason to be sure about that. You could argue a priori, well, it's impossible with this pernicious virus to contain it. But the fact that China, Taiwan, Korea, Vietnam, Cambodia, Laos, Australia, New Zealand have suppressed the epidemic shows that the combination of actions is good enough to get R less than 1. But it requires this very active and participatory process of the public. That comes to my mind to the second level. Why have those countries been able to do it and the United States and Western Europe have not been able to do it? If it had just been the United States, I would say it's obvious. It's the orange man that did it. And he certainly played a huge role. We've never had more irresponsibility than with this president. He's individually and singularly unique in American history. And we see it now that he loses an election, but he didn't lose an election in his delusional world. And the virus was no different from this. No fact would penetrate his narcissism and perceived self-interest, whether delusional or for some electoral reason or some other reason. But it's even beyond Trump himself, because we're seeing Spain, Italy, France also succumbing to mass epidemics in ways that the Asia Pacific have not. And that raises a question, because those countries are better governed than ours in some way, but it's not working there either. And one can say that the process at a technical level, we've all failed. We have not had any consistent contact tracing in the United States. We didn't even have the concept of active surveillance in almost all of the country. We didn't even have the concept of face masks in most of the country. But we didn't certainly have the concept of early isolation, effective quarantine, and active surveillance, besides a few cities in the United States till today. The whole idea has never been explained. The only way this virus is discussed in the US is either we lock down the US or we suffer through it. That's actually been the level of debate, which is imbecilic, but it's been the level of our public discussion till now. So it raises the second level, not the technical questions, but the governance questions. And that is a matter both of competency of government and trust between government and the public, because the public has to also respond, not with semi-automatic weapons carried to state capitals to threaten kidnapping governors, but rather to say, yes, I will be responsible to wear face masks, which is a little less dramatic and a little more effective in actually preventing the epidemic. And this is where I think our sociological analysis is really needed right now. Why have some countries been able to achieve not only effective governance, but also cooperation of the public and a high level of trust between government and the public, and the US and Western Europe have not? And there's a lot to say about that, but what all of our discussion has been with countries where the epidemic has been suppressed has focused on this trust question, that governments have felt capable of doing the right thing and have felt the backing of the public, both in encouraging a serious policy and in abiding by a serious policy. Whereas we've had neither top-down nor bottom-up good governance in the US to actually implement the serious policies. And I see Alison is back. It strikes me as the fundamental point of this, that the United States has how many cases today? 180,000 or something. And China will have 5 for 1.4 billion people. And all of East Asia, all of the Asia Pacific, 2 billion people, will have maybe a couple thousand cases today. And we will have 100 times that number. So this is a controllable pandemic. Alison's framework tells us how to control it. Get out of circulation when you're sick, when you're infectious, but that requires both the technical capacity and the quality of governance and trust in government to carry it out. So that's what strikes me as the lessons of this.
Just building on that, and then Alison, I want you to connect with us and Giannis after that. One thing, I guess one good thing for academics is that we have a lot of observations now. So we're seeing a lot of different jurisdictions handling this in different ways with different levels of success. So Jeff, you were pointing to some of the extremes that we have there, but it is striking, going back to the health system. I'm not sure that's the right word for what we have in the United States, but I'll use that term. That in Alison and I both know the UK quite well. We have in the UK the National Health Service. It saved Boris Johnson's life when he was infected. So even though the UK has an infrastructure, it's bungled in a number of ways. It's definitely have had a similar problem that we've had with very conflicting messages coming out, going to the public about how seriously to take this, what to do, creating a lot of confusion. Definitely there's a lot of ideology in that country and people believing things in a way that's highly correlated with their political affiliation. And the consequence of all that is that they've also had a failure to control, even though they have a public health service that is widely supported and generally a very effective way of delivering health. So I'm curious, I mean, I guess that single comparison, Jeff, related to what you were saying, tells me that the leadership aspect of this, having an infrastructure without leadership isn't also going to be terribly good. You really need the two together. It's a bit like we were saying in an earlier webinar that you need to integrate your macroeconomic policy with your public health policy, because those two things have to work together. And I think it's also true that the leadership's more effective if it has an infrastructure. But the infrastructure also is a lot more effective if there's leadership. And I think it's that combination, and we don't have either. But it's astonishing, even as Jeff said with the masks, which you don't need an infrastructure for masks, even there we've failed. And I think that clearly shows the difficulty of leadership. Alison, what are your thoughts about this?
I think
if I could join in just one specific question. Do you have any insight into something I've not understood at all? Why couldn't CDC just fix its kit, for heaven's sake, for example? Because that's also, okay, it had a glitch, fix it. But we never heard of the fix. We only saw what you showed us, no testing until mid-March.
Yeah. Well, I think the administration also wanted to give big contracts to these corporations to do the testing. Abbott, as an aside, something that I'm looking into, doing a meta-analysis and about all the testing. Abbott, which is the most common test available in the US, the Abbott rapid antigen testing, the company claims that their sensitivity and their specificity is for both are in the high 90%. But they are not comparing, they are comparing against another test that has its own imperfections. So it's not actually, people think that the test is very reliable. It's not very reliable. And they also have not, in their clinical trials, well, they were small sample sizes, they were not peer reviewed, they didn't compare.
So actually, Jeff, when the first cases were notified in Wuhan, both Germany and South Korea started working on diagnostic tests. There was actually a facility in Germany that had pretty advanced research on SARS. And once the genetic material was known and that SARS-CoV-2 was related to SARS, Germany started working on it, South Korea started working on it. So when the US had the first case on January 20th, the same day as South Korea, both South Korea and Germany had tests available, which they offered to the US. The US refused. And so that period between January 20th and March 15 is when the CDC tried, failed, and then corrected it. But sorry, now Alison is back, so she will tell it better than me.
No, that's exactly right. We were offered tests from the WHO, but in our arrogance of thinking we could do it better, we declined the tests. And, we were so much further behind than those other countries. I think with the question that Scott was bringing up with comparison in the UK, the Prime Minister in the UK, initially, he minimized COVID-19. So
I think that this is really worth tracking down in detail again and understanding, because not only were the consequences horrendous, but it could be the absolutely vivid display, as Alison mentioned, of the effect of having lobbyists in position of authority. This may be nothing more than crude contracts with some inside favored companies, which had these absolutely devastating effects, because this is an administration of unparalleled corruption. And we know an insufficient amount about the stories, but we do know that the literal agency heads were directly from particular companies or from associations, company associations, and it may just be this fact, which is so terribly depressing.
I wholeheartedly agree with you, Jeff. Yeah, the CEO of Abbott is an ally of the president and the administration. And speaking of health, healthcare system, with insurers spend more on lobbying than any other industry. Fossil fuels, banking, those are all dwarfed by health insurers. And then that's even a separate category. The number two is pharmaceutical companies. And so that's, I think that drives a lot of not just Republicans, but Democrats too, who also get campaign funding from them. So that's an underlying problem in our country.
So that's on that point, because we're going to say goodbye to the person in the White House pretty soon. Biden has, in my opinion, been pretty impressive. He's been pretty clear about COVID being a priority and what needs to be done. But I'm curious what you think, Alison, and also Jeff, about Biden and what he is going to be able to do, because he has limited. He's got to assert his power as leader, which I think he's making progress in. He's fighting an uphill battle, but I think I've been impressed so far. But he won't have help from Congress, from the Senate, at least not until we hear from Georgia. And so I'm sort of curious what you think. How much of this is something that can be turned around? That relates to one of the questions that a student had. Well, okay, we've got these various problems in the U.S. Are there some things we can do that would have a big impact? And maybe we could then build on that. So what can we do, and what might we expect from a Biden administration, apart from people expecting, the miracle of a vaccine to save everything, and therefore we don't have to worry about corruption and ineffectiveness and all the rest of it. But what kind of simple things can we do that would have a big impact?
To talk about the question that you asked earlier about the difference in leadership and why the US and Europe is so different from Asia, how much do you think culture has to do with this? My limited knowledge of Asian culture tells me that, people don't greet each other with contact. There's no handshakes, there's no kisses like you would find in Southern Europe. People are also very respectful of other people's health. As soon as they have a mild scratch or anything, they will not go to work, or they will wear the face mask. Whereas in Europe and in America, the idea is you just tough it out. You feel a little bit under the weather, you still go to work. And I think that's one of the mentalities that if we can change anything through this pandemic, it's probably that. So how much do you think that actually plays?
Well, one thing that is very interesting for us is Australia and New Zealand, because these are two Anglo outposts in the Pacific region that have done extremely well with a culture that is very familiar, not an East Asian Confucian-based culture, but very much an English culture. And it's interesting, partly I think they did well because they're in a region that did well. So all of their comparisons were comparisons of countries that were being effective, and that helps. So there's a certain kind of contagion of good or bad practice. And I think that afflicted both Europe and the US, that we didn't have good role models. And when you have the Wall Street Journal asking, is the US doing well or badly, it always compared to France and Germany, not compared to Asia. So the comparison group makes a big difference. And I think that there was a better comparison group. But the Australian Secretary of Health explained to us recently that as soon as the outbreak hit, they created first tests around an academic network. So they basically did, like the Koreans did, have tests up and running early. And there was a structure of community health that they could mobilize. So that was the second point. Third, they were quite afraid of the virus from the beginning because they had been through several scares, including SARS. So the historical memory definitely made a difference. The fact that it came from China worried them. This could be something very serious. So they took a lot of precaution. And then they organized in ways that we did not. He explained that though this is a state level responsibility in Australia, every single day, the Secretary of Health of the federal government was on the phone with each of the secretaries of health of the state governments for 2.5 hours a day to go through national protocols together to create them from state and central government in a unified way. I wonder if we've had even one phone call. I don't know, but I wonder if we've had even one phone call in the United States of health commissioners across the 50 states with somebody in Washington on coordination. I somehow doubt it. Maybe there was such a call, but it wasn't 87 straight days for a couple of hours a day. It was just taken much more seriously. And then what was explained was that given that top-down seriousness, there was a bottom-up agreement. We trust this, we will follow through. And, this pretty rambunctious culture, not quite US, but they can get into some pretty tough brawls over rugby or over sports events and so forth. But people were very, very solicitous of the government advice and followed through. So I think that in this context, it is a little mystery. I'd say it's partly a neighborhood effect. It's partly what you say, or I think a lot of what you say around for mainly China, Taiwan, Korea, Japan, Singapore, Hong Kong. For Australia, New Zealand, not so much. Maybe if they had been in Europe, they would look more like the European outcome. But because they were in a neighborhood, had a neighborhood effect and a memory of SARS and H1N1 and MERS and all the rest, they felt better prepared for it. But fundamentally, in the end, there was a lot of trust. And I think it's also true we should give credit to the particular leaders in many cases. Jacinda Ardern in New Zealand said, we're going to go to eliminate this virus from our islands. We're going to get rid of this. It's going to be tough in the short term, but she's a very effective leader. The public agreed, and then they returned her to her new term with the overwhelming majority vote. And so it's also, and incidentally, you know, it is amazing. Good public health was good politics. So had Trump acted better, I think the evidence is pretty clear. He would have won re-election. Even with a very difficult spring and summer economically, had he followed through in a different way, given this narrow margin, my guess is he would have won at the polls.
You know, remembering some of your work, Jeff, on geography, would have thought that probably helped New Zealand, probably especially, but Australia too a little bit. But I was looking while you were speaking at the numbers for Canada. So there's another country, you know, Anglo-Franco as well, but they have 11,136 deaths.
Yeah.
If you adjust for population, basically they're having, less than half per capita that we're having, and they're right next door, and so it's clear. Absolutely, I mean, I'm not saying that they're the standard we should aim for, but it's clear
They
that,
did better.
Yeah,
Much better, much more rational.
And the worst thing about this is there's been this abject failure and a failure on the part of about half our citizens to acknowledge that this was avoidable and that there was a lack of leadership, there's corruption, there's all sorts of things in play here, and it's been incredibly destructive to the American society. Alison, are you there?
Hi. Yes.
Okay. So maybe at this point, Yannis, did you want to add anything?
No, in the interest of time, I think maybe Alison can have the concluding remarks.
Yeah, Alison, maybe you have some final thoughts you want to share with us, some, a main point you want to leave us all with.
Well, I think there is optimism from the last few days. These vaccination results are really extremely promising, being high efficacy, above 90% for two candidates. So that, and including in elderly people. And it seems like there is, not only is it protective against infection, but then if you are infected, having been vaccinated, then there's also protection against severe outcomes. So that is extremely heartening. That's a better efficacy than I expected, both of them better efficacy. And I think that the new administration will put, I think, and I really hope that the new administration will put the resources into scale up production so that vaccination will be widely available in the U.S. and beyond. And although this Thanksgiving it's not safe to go and have multi-generational get-togethers, I think by next Thanksgiving, if these vaccination results about with sample sizes are increased and scale up and equitable distribution is implemented, this pandemic will be behind us. So I just want to sort of end on an optimistic note, because I do appreciate how fatigued everyone is with this seeming like an endless battle.
Thank you, Alison, for trying to create some optimism on a landscape that's otherwise relatively bleak, but also mixed. We're learning from that, right? We could have done better. We're seeing other places have done better. So we definitely need to learn from this, and I hope there will be an exercise of learning, and that will bring about some change. We need some major changes in this country and elsewhere. There hasn't been coordination within the US, but there really hasn't been coordination globally either, the way there should be.